Good evening, everybody on the call. My name is Tom Roz. I'm the moderator of today's AO-sponsored symposium on cervical spine, return to play in collision sports. I am pleased and proud to announce our two distinguished guests. Wellington Hsu is the Clifford C. Racebeck Distinguished Professor in the Department of Orthopedic Surgery at Northwestern University. He is joined by our national and international colleague, Andrew Hecht, who's Professor of Orthopedic and Neurological Surgery at Mount Sinai Health System. Both are very distinguished when it comes to the management of elite athlete injuries. Both have a very storied history of publications on elite athletes on a multitude of different professional sports, and they are content experts. And so I was pleased when they decided to join us for this important symposium. Our disclosure information, including myself, Dr. Hsu and Dr. Hecht, is presented there. And you can take a few seconds to take a look. And if you have any questions regarding our disclosures, feel free to contact AO Spine for any further information. The overview of this particular guideline collision sports symposium is to provide content on the variety of different topics, and we'll go over that when I speak about the agenda. The learning objectives: upon completion, the participants should be able to describe the key principles and nuances to cervical disc herniation in collision sports, and to discuss the key principles and nuances to asymptomatic and symptomatic central cervical stenosis in collision sports. And finally, 3, recognize the implications of cervical surgery for the above problems on the elite athlete. Our agenda will start with Dr. Hsu, who will speak about cervical disc herniations and return to play. Following his short lecture, he'll also go over some key cases. This will be followed by Dr. Hecht's lecture on cervical stenosis and return to play, and likewise, he'll also be discussing several cases. After the conclusion of Dr. Hsu's and Hecht's presentations, we'll have a discussion where we can certainly answer any of your questions or comments. And then finally, at 9 or shortly before 9 o'clock, we will adjourn for the evening. I would like to turn the stage over to then Wellington Hsu. Wellington, I'm going to stop sharing and you can start.
Thank you very much, Tom. It is a pleasure to be part of this esteemed panel and to be talking about a topic that is very near and dear to my heart, cervical disc herniations. And so I'll spend the next 15 to 20 minutes talking about what the data and what expert opinion may think about a cervical disc herniation, not only in the general population, but in the elite athlete, and how we manage these issues. And Dr. Hecht will shortly after me talk about an issue that's very prevalent that includes cervical stenosis, and some of these issues go hand in hand. These are my financial disclosures, none of them which pertain to the topics at hand. But these are my current spine consultancies. I am associated with the Northwestern Sports, or all the Northwestern Sports teams, which is a Big Ten team. My practice also takes care of the Chicago Cubs and the Chicago Blackhawks. And I also am a member of the Head, Neck, and Spine Medical Committee. But none of my opinions that I will be expressing today are represented at all by these organizations. These are opinions from my own research and my own practice. So the issue at hand is the cervical spine. And this is a topic that really wasn't even a topic decades ago, because we would just group elite athletes into the general population as to how we deal with cervical disc herniations and other kinds of issues. But there are very important questions as to what return to play criteria are, and this will vary greatly depending upon an individual sport, their position, and what their pre-existing conditions are. Over the past decade at Northwestern, I've been proud to lead an effort called the Sports Professional Orthopedic Research Tool, in which we've amassed over 3,000 athletes over 7 professional sports over a 40-year span. And I would like to recognize the contributors of this effort, which would include residents, medical students, and my colleagues. And through that, we're able to collect data to be able to use some type of evidence-based guidelines in order to deal with disc herniations and other maladies that affect elite athletes. And the reason this is important is because a 59-year-old female who suffers from an acute C7 radiculopathy with triceps weakness and 10 weeks of symptoms, there are many different considerations for her than if a 24-year-old male who plays wide receiver in the NFL has the exact same symptoms with the exact same pathology. The acuity of the treatment, the long-term ramifications of treatment, all of this will differ, and we do need to treat these individuals differently because of the relative differences in the presentation. The professional athlete is a high-risk population when it comes to cervical conditions, and American football certainly leads that list. There's high-velocity trauma. There are conditions that are specific for collision sports, such as spear-tackler spine, and they're really unnatural loading patterns on a regular basis. Hyperextension, axial loading, rapid rotation, and even poor tackling habits can lead to all of these issues that come about. About 9 years ago, we were able to publish the first paper that represented the largest database of professional athletes who played American football and determined their outcomes after cervical disc herniation. And at this time, there was a real question, and I would say that we've answered these questions a decade later, but a decade ago, we really didn't know if collision athletes should be having cervical surgery. And if you polled all neurosurgeons or orthopedic surgeons across the board, only half would agree to returning a player back to a sport after a one-level ACDF. And now we are much different now because of the data that's been available. But there are still questions. Are elite athletes at risk for spinal cord injury after spinal surgery? And then finally, would you clear a football player to return to play after a cervical fusion? The data we were able to publish at that time indicated that a ACDF or a fusion is compatible with return to play to a collision sport. And this is the type of recommendation and universal consensus that we have at this time for one level. And this study showed that if you had surgery for a ACDF, you had a significantly greater chance of getting back to play and having a longer career, although we recognize that there was bias in this data. So we were simply able to conclude that having a one-level fusion is compatible with return to play. Now, one of the unique findings of this study that was unexpected was that the position that these players played certainly determined and was a prognostic indicator as to their outcome. And so many of these positions for our international audience may not mean a whole lot, but I can tell you that each of these positions on the American football field represent a different type of player, a different type of body habitus, a different type of speed, a different type of demand on the cervical, on the lumbar spine, and a different risk of re-injury. And we happen to show that the defensive back, which is a player that is typically a little bit smaller and thinner, yet the most athletic position on the field, seem to be overrepresented in the population for this particular study. And then we went ahead and looked at all positions and determined that these players who played defensive back had a shorter career, had a poor outcome, and they were in a category of their own in terms of outcome after treatment for a cervical disc herniation. We did find that the risk of a second operation or one for adjacent segment degeneration was about 5% over the 2-year length of the study, which is typical for the general population. This position represents perhaps one that has a very low threshold for losing range of motion of the neck. These players are smaller and they're tackling players that are much heavier, and they need their necks and their heads and their helmets in order to bring people down. So it's not a far reach to say that a cervical disc fusion for an individual such as this would be different from a quarterback or an offensive lineman, in which the physical demands would be significantly different. And this was certainly borne out in the anecdotes where defensive backs would actually come out and say that their football careers were not the same after being treated for cervical disc herniation and how they weren't the same player. The second question that often comes up and still is not resolved, I would say, is that is there a difference in how we treat a disc herniation for either an upper or a lower level segment? So, for example, a C5-6 disc herniation, is there a different implication for fusing that level versus C3-4? And there could be, because the risk of adjacent segment degeneration at C2-3 is far greater than at C4-5 because of the inherent nature of the spinal cord at that level. And is there a risk of spinal cord injury? So for years, and even currently, there still is debate as to whether or not a C3-4 ACDF is compatible with return to play for many individuals who treat these players. So there is data on this, and we looked at our database and divided 40 athletes that we knew the levels in which they had surgery into upper and lower cervical level fusions. And these are not huge numbers by any means, but it does shed some light as to whether or not a upper cervical fusion done from the front is compatible with return to play. What is interesting is that we were the first to show, although many individuals who treat these players knew it all along, is that when we look at the relative incidence of the general population in terms of where you see a cervical disc herniation, most commonly you're going to see it at C5-6 or C6-7, which makes sense because this is the greatest range of motion that would predispose someone to getting a disc herniation at that level. But if you look at the NFL players of our study, the distribution is different. C3-4 happened to be overrepresented, and you can see here that a C3-4 disc herniation in the general population is not very common, but in a collision athlete who wears a helmet, perhaps these forces on a daily basis predispose that level to getting injured. We were able to show that a high percentage of collision athletes had upper level pathology. But despite that, the performance after fusing or treating the upper and lower cervical disc herniations was the same. So whether or not you had a fusion at an upper or lower level, your career length in games and years, and even your performance score was expected to be the same. And this, in my opinion, has been a breakthrough, since many individuals who had in the past not cleared players who have had a C3-4 or an upper level disc herniation treated with a fusion have not cleared them to return to play. I think we're seeing that change now just because of some of this data, and that we know that the relative risks are low, at least with the data that we have. So the next question then would be, since there are many different ways to treat cervical disc herniations, what impact does that have on performance-based outcomes? So ACDF, probably the most common way we treat a disc herniation, it can also be treated with these disc herniations with foraminotomy posteriorly, even a total disc arthroplasty, which obviously is a newer technology, but many players want this type of technology if they are well read on the incidence of adjacent segment degeneration and such. So in this particular study from the Clinical Spine Surgery published 3 years ago, we looked at 101 professional athletes that had a different procedure for a one-level disc herniation and classified them by sport, hoping to show a difference in sport in terms of outcome. And then we compared their outcomes in the end. So there certainly was a trend in a huge majority of these individuals that had an ACDF. And because the data was collected over 40 to 50 years, it made sense that more folks were doing ACDFs early on, and foraminotomies a little bit more recently. And one of the starkest, or I guess one of the most interesting conclusions that we were able to make is that individuals who had a foraminotomy, although many of them did well, had a reoperation rate of up to 46%, which was significantly greater than that of the fusion or the disc arthroplasty group. Now, this obviously doesn't mean a foraminotomy isn't helpful, because on the flip side, if you had a foraminotomy, you had a significantly higher chance of returning play, and you had a decreased recovery time, which is what we would expect for a foraminotomy that doesn't require any instrumentation. It's just a decompressive procedure. So for an individual who is thinking about a foraminotomy or thinking about getting one, I think it's important from this data to show that there's a higher chance of a reoperation rate. But if the injury occurs in the season and the season is longer, it is also reasonable to consider a foraminotomy to get a player back to a certain level that year, and then with the known risk that there could be a fusion or some type of definitive procedure later on. So what we were able to conclude is that the reoperation rate in the general population is about 5%. In this study performed by Wong and Dr. Mraz was involved as well, also shows that there is a higher rate of reoperation in the younger, more active individual, which is the exact demographic of what we're talking about in front of us. We were able to show that 4 of these individuals in this group required a fusion after a foraminotomy, and notably, there was no difference in recovery time compared to these fusions versus a virgin fusion, meaning that these individuals could get a fusion and still do well and return to play at a high rate. Again, but these are very small numbers. So to conclude, as far as disc herniation is concerned, we believe that ACDF and foraminotomies are both viable options. Total disc arthroplasty simply just doesn't have enough data around it, although there are 2 Major League Baseball players that have had a total disc arthroplasty and successfully returned to play long careers. We just don't have any other data for total disc arthroplasty in professional athletes, but there are data on NCAA athletes and as well as military personnel, all showing good outcomes. Foraminotomies have a faster recovery time, a higher return to play rate, and a higher rate of reoperation, whereas fusions have a slower recovery time, lower return to play rate, although still acceptable, and a lower rate of reoperation. We know that the distribution of disc herniation is different from athletes compared to the general population, with the upper level cervical disc herniations being more common, and that concludes those conclusions. As far as return to play criteria, these are the 4 criteria that I'm always keeping in my mind when I'm looking at an individual in my office, trying to determine whether or not he or she can get back to play, regardless of the cervical condition. Whether it's stenosis, whether it's a disc herniation, a congenital problem, this will be highlighted in some of the cases that we talk about. And this comes down to how do they clinically present, what their physical exam findings are, what does the imaging show, and then finally, perhaps most importantly, what is the type of sport that they play. So for clinical presentation, it is very important to distinguish between a radiculopathy versus a stinger-like symptom. Patients can have transient quadriparesis and not really know it until it gets brought out of them of what their actual symptoms were or are at the time. And then myelopathy. Many of these individuals, you wouldn't expect to have myelopathy because of the way they look or how strong they are in an exam or how they perform in a field. But many of them also have these symptoms that can be teased out and they can last for a year or a decade or their entire careers, and they never knew they had them, including coordination difficulties, transient numbness, and even this Lermits sensation that we know is having mnemonic for this condition. On physical exam, motor weakness, upper motor neuron signs, range of motion, exertional testing all come into play as far as whether or not one can return to the field. And clearly all of these have to be normal in order for that to happen. Imaging is an interesting one, and I'll let Dr. Hecht sort of talk about the issue with cervical stenosis. There are many controversies on whether or not myelomalacia, T2 core signal intensity, T1 core signal intensity, whether that represents disqualification criteria, whether it's independent of physical exam findings. I'm certainly in the camp that one who has persistent myelomalacia on an MRI, I would typically not let that individual return to play, even if they are asymptomatic, because it may highlight or signify an intrinsic change in the spinal cord. And then finally, the type of sport is important. And I've given a lot of thought to this based on all the research that we've done in the last decade. And as far as spinal problems are concerned, there are many different categories that I think are important to institute, including separating the difference between non-contact, contact, and collision sports. Because in my opinion, contact sports are grouped together, but there should be a further or another classification, because there are many conditions where I would allow a basketball player to return to, but not necessarily a rugby athlete or boxing or MMA Again, these are just my opinions, but I believe that this type of sport is important in the algorithm in that determination. And then finally, rotational sports such as golf, tennis, cricket, field from track and field. These are important to the lumbar spine and should be separated out for that reason. Many hot topics, I would say, involving disc herniations now, including whether or not a 2-level fusion can return to play to a collision sport. There is some data to suggest that this can happen. Rugby players have returned after 2-level cervical fusions. There are more than 10 or 20 that have been reported in the literature. There is an NFL player that has returned after a 3-level posterior fusion, and this is based purely on anecdotal evidence. And multiple military personnel have returned to active duty after this procedure as well. So it goes to show that although this is a relative contraindication to return to play now, maybe we need to rethink this because we have to weigh the risk of injury with the risk of return. And in my opinion, if there is evidence to show that it's compatible with return to play, then we should certainly think about allowing our individuals to go back. And then finally, what about osteoarthrosis? This is a very controversial topic that you won't find any consensus on, but it's not uncommon. This is a 26-year-old male who I saw who was a quarterback and had a C3-4 ACDF to treat a cervical disc herniation, was completely asymptomatic, had full range of motion, and was completely neurologically intact. But as you can see in the X-ray, did not have complete healing. So the way I sort of think about this is that we know that pseudoarthrosis is relatively uncommon. Only a subset are symptomatic. There are asymptomatic pseudoarthroses that do not need treatment in the general population. We know this. About 1/3 of individuals are asymptomatic and don't have any issues and have a pseudo and do just fine. So the concerns in the high risk, the concerns in the athlete include possible hardware migration, risk of spinal cord injury or failure, and the risk for further surgery. And we're of course talking about an asymptomatic pseudo at this point and whether or not they can return to play. So the way I would look at it is that the risk of hardware concerns is very low. It's about 0.1% as reported by Fountas. Could this happen if you got, or could it be higher if you got back to a collision sport? Yes, it's possible, but in my opinion, unlikely. The risk for spinal cord injury has been 0 in NFL football athletes after an ACDF. Now, you could argue that these aren't individuals with osteoarthrosis, but again, I think that this risk is pretty low. And the risks for the need for future surgical repair of osteoarthrosis really don't change, in my opinion, if you allow that individual to return to the as the individual knows what those risks are. So again, my opinion as to how to deal with osteoarthrosis for these reasons, we don't have any data on how individuals do with osteoarthrosis. And there are many out there, I'm sure on the call, who would even disagree with me and say that they would not clear an individual back to a sport with osteoarthrosis. But again, it deserves discussion because there is really no data to hang our hat on. So I'll end with saying my philosophy in treating athletes is that surgery is always the last option. We really need to separate return to play and long-term clinical outcomes because the clinical outcomes is really how they perform on the field, and that's what athletes want to know. We always want to consider the most minimal surgery required to return to play, and we can't accept dogma for these athletes. We can't simply just say, well, this is how it's always been, so we should disqualify them or not allow them to play. I think we really should be looking at more recent data. So to conclude, cervical spine conditions can be life-threatening. The natural history in these athletes is different than the general population, so we should treat them differently. Surgical treatment is compatible with high return to play rates, and this has been published now a few times since our initial article. And outcomes are definitely different depending on the surgery. And most importantly, the position on your field matters, not only the sport that you play. I'll leave the stenosis issues to be discussed by Dr. Hecht, but I'm sure he will agree with me that the return to play criteria should be multifactorial and take all individual characteristics into account. Thank you very much.
Thank you, Wellington. And I think at this point you can go through your cases if you want.
Sounds good. Okay, so share again. Sorry. Okay, so I picked 2 cases. Again, I don't want to steal the thunder from Dr. Hecht here. But I will say that there's a lot of controversy as to when to allow an individual get back to playing a sport or activity if he or she has stenosis. So on one end of the spectrum, an individual can be playing quarterback, which in my opinion is a lower risk position compared to like a defensive back. It could be completely asymptomatic and have 14 millimeter sagittal canal distance on MRI. I think few would say that this individual should not get back to play. Most would just say, yeah, this guy's clear. On the opposite end of the spectrum, you'll have an individual with 3 transient quadriparetic events where they're temporarily paralyzed, have 8 millimeter sagittal canal distance on MRI. And almost everyone, in my opinion, would say that this individual should not get back to play because the risk is too high. So really the gray area though is very wide. So you'll have an individual who maybe has 1 transient quadriparetic event, have enough sagittal canal distance but has functional cervical stenosis, or then you may have another individual who's asymptomatic and that has 10 millimeters on MRIs, kind of towing that line. Do you allow that person to go back to play? So again, that's how I sort of look at the continuum of cases for cervical stenosis. This happens to be a case of one of our star athletes who was 20 years old at the time, certainly had NFL aspirations to get back or to play running back, was our starting running back. Had 2 episodes in one game during the season though, where he had numbness and tingling in his arms and clumsiness after taking a hit. He continued to play. He never sat out a snap or a series, but he just noted that this was what happened. He couldn't control his hands for a short period of time, but then it all returned. Upon further questioning, he admitted that there were a number of similar transient episodes in high school while playing football. In fact, he said 12 to 14, never told anybody because he didn't think it was significant, and he thought everybody just got these kinds of symptoms. But on exam, he was neuro intact, he had full strength, he had full range of motion, he had no neck or arm pain, completely asymptomatic. And then as you can see from the MRI, this MRI shows congenital cervical stenosis. And we measure the sagittal canal distance at 7 millimeters. So again, this case is really just for discussion. In my practice, someone with a sagittal canal distance of less than 8 millimeters will not be able to return to play, will be disqualified from any collision sport, regardless of symptoms, because of some data, in my opinion, that shows that there is a higher risk of sustaining a spinal cord injury with that type of picture. So with this individual being 7 millimeters, and furthermore, he's got symptoms of transient quadriparesis, we ended up disqualifying him despite the fact that he was completely asymptomatic and he only had a couple episodes of these symptoms. And then this symptom, in my opinion, is a form of, a very mild form, but a form of transient quadriparesis where there are spinal cord symptoms after a hit or after a trauma. So yeah, so I mean, I think the real question would come in, if somebody had a slightly larger canal distance and was asymptomatic, but again, I don't want to steal Dr. Hecht's thunder and let him discuss that. The second case I just wanted to bring up, and I thought it was interesting and does illustrate the importance of the sport. This is an individual who was our starting point guard a few years ago, had an acute neck injury during practice 3 weeks prior, which led to this x-ray. It wasn't that he had any chronic pain, he didn't have any radiculopathy, he didn't have any symptoms other than just having this acute neck injury, so he got this x-ray. And this x-ray shows a congenital spondylolisthesis. There's a pars defect at C6, and there is a spondylolisthesis at C6-7. And you can see with flexion extension, there really isn't any instability, but you can definitely see that the facets are sort of riding on each other, especially in this flexion film here on the right side, if you can compare it to the extension. So he presents and is completely asymptomatic. And so the question is, what do you do with this individual? Do you allow him to get back to this sport despite having this congenital issue that seems to be stable? And I thought about this a lot because this is not the first congenital issue that we've seen in individuals who have played their entire careers on. But I think each of these congenital problems deserves their own analysis, deserve their own evaluation. For this individual, playing basketball, in my opinion, is low risk for having this develop into a chronic or an acute problem that would lead to a spinal cord injury. So we certainly, after much discussion, we discussed what would be involved in terms of clearing them to that sport. And as a team, we ended up clearing them back to basketball. The real question, in my opinion, is what if this individual played a collision sport, such as rugby, American football, hockey, was an MMA fighter, all of these things. And I would say if I had this case, I would probably say that a collision sport is not compatible with this congenital problem, solely because inherently this could become unstable if there were a certain hit, and there's probably a lower threshold and is more unstable with the type of hits that a American football player needs to go through on a daily basis. So again, just kind of highlighting as to why this pathology is important depending on the individual who comes into your clinic and decisions have to be made. But again, these are just my opinions, and I think this is an interesting one just because my recommendations would be different depending on what this individual wanted to do and what sport they played.
That's fantastic. Thank you, Wellington. That really is an interesting case. Andy, you want to take it over?
Sure.
And if anybody has any questions, please put your question into the Q&A. I'll library it and we'll come back to it towards the end of the session.
You guys see my thing here?
Yes, sir.
Okay. All right. Thanks, Tom. Thanks, Wellington. Wellington, that was fantastic as always. This is sort of a continuum. Wellington's talking to my talk, and one of the really challenging problems facing anyone who takes care of athletes is what do you do about people with cervical stenosis, be it asymptomatic or symptomatic cervical stenosis. These are my disclosures. I know I've been the spine consultant for the Jets and the Islanders for, about 15 years now, and I formerly sat on the NFL Brain and Spine Committee that Wellington sits on now. So I've seen a few things. One of the things that we see taking care of NFL players and athletes, unfortunately, are these kinds of dramatic moments where there's a head-to-head collision and right away something's not quite right. And you'll see, this is from Wellington's hometown in Chicago, where Devontae Adams has a head-to-head classic spearing episode where he's literally unconscious. Now we know this is where you see the hands waving and everyone's heart drops, and we see these kind of episodes and we know what's here. And what's good about this case is he woke up and completely moving everything. So one of the big questions is, how can we figure out, as Wellington was making some comments during some of the cases, is can we predict who is at risk of a spinal cord injury, even if someone's asymptomatic? Remember, most athletes present with symptoms after a trauma. An athlete who has a cord neuropraxia, like with a herniated disc, will get surgery even if they become asymptomatic. So an athlete with a defined lesion will get surgery if they have a cord neuropraxia. Athletes who have congenital stenosis, who get a cord neuropraxia, they're usually going to retire from playing if they have more than one of these. And obviously, most cord neuropraxias in the setting of stenosis are usually multi-level problems. But an athlete who has a cord neuropraxia who has no stenosis or no herniation will often return to play. So how do we predict? At the NFL level, we often are being asked to evaluate asymptomatic athletes and predict risk. The greatest example of that is the NFL Combine, where incredible amounts of imaging on borderline asymptomatic athletes with the most minor history of neck pain or minor episodes are evaluated de novo with MRIs, CAT scans, x-rays. Almost in all other sports, we don't see these athletes until some sort of injury or clinical situation has arisen, whether you have neck pain, you had a stinger, a cord neuropraxia, what have you. So here's a case of a 21-year-old defensive back with a stinger in high school that resolved after a few minutes, played 4 years without incident, comes to the combine and gets this MRI. Are you going to draft this guy? Are you going to clear him to play? Does he need surgery? So the problem is, can we predict risk and severity of a spinal cord problem after a minor trauma to the cervical spine? Can we predict it even without any preceding neurologic symptoms? And is cervical stenosis really the key between the discrepancy of the severity of the injury and that of the trauma? Obviously, we all know the Torg-Pavlov ratio. It's easy to calculate, but it has a low predictive value due to the variability in vertebral body size, and it's very hard to assess narrowing due to soft tissues. Dr. Torg has really set the bar with evaluating the problem of cervical stenosis, and he postulated that there's a relationship between the cord neuropraxia and a developmental narrowing of the cervical canal from his classic paper in the 80s. Obviously, we all know how to calculate this Torg ratio of a spinal canal to vertebral body ratio, and that's pathologic less than 0.8. And it's a key imaging marker. In his study, he looked at 5 groups of people: 227 asymptomatic college football players, 97 asymptomatic professional football players, 45 players that had at least one episode of a cord neuropraxia, and 77 former football players who were quads, and then 105 male non-athletes. What they saw on this screen here is that basically, and if you look at the spinal canal dimensions, the cord neuropraxias had the smallest spinal canals, but look where the quads were. They were lumped with everyone, including the non-athletes. If you look at the vertebral bodies, the non-athletes had the smallest vertebral bodies, but the quads had an intermediate side, but the cord neuropraxias were up here. And looking at the Torg ratios, the athletes who had cord neuropraxias had the lowest Torg ratios, but look where the quads were. The quads were up here. So the mean Torg ratios for the cord neuropraxias were significantly less than any other group, but you couldn't pick out the quads ahead of time. The ratio proved to be very sensitive, but non-specific, making it sort of a poor test to screen for those at risk of a cord neuropraxia. And we thought, and the thought was from this study that developmental narrowing of the canal shouldn't preclude an athlete from playing. And what was interesting is that none of the 77 quads in the study had a warning sign, meaning did they have a harbinger cord neuropraxia prior to this devastating episode of quadriplegia. And none of the 45 individuals, of the 22 of the 45 individuals who returned to play, had any permanent neurologic injury, but this was only for a season or so of follow-up. However, they went deeper and they looked at the athletes who had a witnessed episode of a cord neuropraxia, and they contacted them. Obviously, most of them had developmental narrowing of the canal with Torg ratios less than 0.7. Most of them had disc level canal diameters of about 10.1. Of the 63 of the 110 individuals who returned to contact sport for at least one season, this group didn't differ in almost any other aspect: age, type of sport, the grade of cord neuropraxia, or any other radiographic finding or measurement. Half of them had another episode. Some of them had lots of episodes. Sort of as Wellington's case showed, you may have, on further questioning of one of these athletes, they may have had lots of them. They may have even been thinking that this was a stinger when they had bilateral numbness in their arms, and not knowing that a stinger is only a unilateral upper extremity phenomenon. And in the study, there was one athlete who had 25 cord neuropraxias. The risk of recurrence of a cord neuropraxia is the real deal. And I always tell athletes, if you've had one, there's a pretty good chance you're going to have another. And all radiographic measurements, with the exception of actual cord diameter, were predictors of recurrence. So if you look, as your canal diameter goes up, probability of recurrence goes down. As your torg ratio goes up, your probability of your recurrence goes down. So he continued to follow, he followed these athletes over 40 to 51 months. Nobody had a permanent neurologic injury secondary to contact athletics, but sort of common sense is sort of leading us otherwise. A lot of these athletes call it a day after one or two severe episodes like this. We know that cord neuropraxia is a transient phenomenon, and that the cord compression is really related to the narrowing of the diameter of the cervical canal. So I always look at patients without spinal instability or cervical stenosis. The cord neuropraxia without instability and no cervical stenosis can return to collision or contact sports or any sport with really out increased risk. However, if you have a cord neuropraxia and you have canal narrowing, the risk is greater than 50% that you're going to have another one. And those are the ones we really want to identify and have the heart-to-hearts with, because really more than one or two of those is a relative contraindication. So we're often faced with this dilemma. What do we do with an athlete who comes in with neck pain, for example, who may have a spinal canal diameter of 7 millimeters, 8 millimeters, a really narrow torg ratio? So a very interesting group of papers came out over the last several years, taking the daunting task of saying, can we predict someone who is at a higher risk of having a spinal cord injury from a minor trauma of the cervical spine? And this group looked at 45 patients who came into an emergency room with a spinal cord injury, and they compared them to 68 other patients with minor trauma with no spinal cord injury. Now, obviously, these are not football players, hockey players, rugby, MMA fighters. And they looked at this group and they came up with these were patients who had falls, skiing injuries, diving, airplane parachute injuries. And they found out that if they used a Torg-Pavlov ratio of a value of 0.7, that they had a greater likelihood of predicting the occurrence of a spinal cord injury. This was a very specific, if they used this value, but it wasn't very sensitive. But there was no difference in the Torg-Pavlov ratios amongst the different Asia impairment score groups and between patients with complete, partial, and no recovery of symptoms. They took it even a little bit further. They did the same kind of study looking at further imaging characteristics, looking at Torg-Pavlov ratios on MRI, looking at the disc level sagittal diameter. You heard Wellington talking about when he sees someone at 8 or lower, he starts getting very uncomfortable letting anyone go back to a contact or collision sport. And when this study, when they used the same principle of study, 52 acute spinal cord injuries compared to 131 other people who didn't have deficits after minor trauma, if they use the 8 millimeter number as the sagittal disc level canal diameter, they had the largest positive predictive value and likelihood for predicting spinal cord injury. Again, I'm not going to bore you with these tables, but so they went from a Torg-Pavlov ratio, they drilled down even further, doing it on MRIs rather than plain films, and then drilled down to a disc level canal diameter. Now, they went even further, this group. They started looking at even more elaborate measurements, looking at the sagittal diameter of the canal minus the sagittal cord diameter. And they also started looking at the cord canal area ratio, things that are not easy to calculate. Or this thing called the space available for the cord, which is basically subtracting the subarachnoid space from the diameter of the spinal cord. And they found that these things were very, very predictive of spinal cord injury in the same model of study. Meaning, should we really reconsider the threshold for identifying at-risk cervical stenosis patients. In my practice, taking care of lots of NFL players, NHL players, university athletes, when someone has a cord neuropraxia and has cervical stenosis more than once, they've had their second episode, we're sort of talking about stopping. But we're really pushing the envelope here and looking and say, hey, are there features, and this is the gray area. This is not a hard and fast thing that we have the answer for. But what if we dial down some of these thresholds and re-looked at the Torg-Pavlov ratio and lowered it to 0.7, or we considered these things like the MRI disc space canal diameter and lowered it to 8, or some of these more elaborate measurements. Maybe we'd have a better hope in the future of identifying at-risk athletes. And at least we could counsel athletes in higher risk sports like football and rugby. And I think, when most of the time, a lot of times we see athletes with cord neuropraxias who have a focal disc herniation. That's an easy problem to solve. You have a cord neuropraxia, you have a lesion in the canal, that has to be fixed, whether you're asymptomatic or not. There's not a lot of papers on laminoplasty in the athlete who has a congenitally narrow canal. There are a few case reports of a few athletes in basketball and some non-collision sports who have had laminoplasties and have returned to play. And I think there's very little to be gleaned from the non-athlete population, but this last group of investigators really went a little further and really highlighted this area, trying to say, hey, are there novel ways we can look at this? All right, thank you very much.
Thank you, Andy. Do you want to jump into your cases?
Sure.
That was fantastic.
Okay.
And again, I would just prompt the audience to use the Q&A line. If you have any questions for either of the speakers, please put them into the queue. I'll take a look at them and we'll address them after Andy's done with his cases. Thanks.
All right, I'm going to show you just a hodgepodge of some cases and some things. Wellington brought up the issue of the cervical nonunion in his talk. And this was a player I had seen who we were asked to look at, should we sign this player? And he had an ACDF, he was a defensive back, and he was 9 months out from his surgery. He was asymptomatic and he had no pain. And this was his CT scan. Now, there are non-unions and there are non-unions, and this is a whopper of a non-union. And to me, being a defensive back, as Wellington pointed out, is a very unique position. So we thought this guy was pretty high risk of developing symptoms, so we elected not to sign this player because of this, we thought, increased risk. So he ended up going around to many different teams looking, and no one would sign him because no one wanted to take the risk. But the thought was, this is really a fixable problem. And he ended up having surgery at another institution where he didn't have his index procedure, where he had his ACDF converted from an allograft to autograft, and he went on to heal. Unfortunately, never returned to the NFL. Another case that we showed was a 16-year-old boy who was wrestling, who had numbness and tingling in both arms. Fortuitously, he knew something was not quite right, and he had some soreness at the end of practice. And his neighbor, who happened to be a nurse, and said, getting symptoms in both arms is not a stinger, Mom. He should be brought in. And this is what we saw. And here's a young man who had an os odontoideum who was wrestling, who had significant instability on flexion extension films. And this, we immediately said, this is not someone who should return to contact sports like wrestling, and had to be pulled, and this thing had to be fixed. And he ended up having a C1-2 fusion and did very well as asymptomatic. And now, what about a C1-2 fusion? What about he's 16, can he go back to doing other sports? And we basically had cleared him to do non-contact and non-collision sports. So he could return to those kinds of sports. So here's another interesting case of a linebacker who had neck pain in the final game of the season, and got an MRI, and he noted this incidental disc herniation. But on further examination, something was not quite right here. So he had a more extensive evaluation, and he had this C3-4 disc herniation, but he also had a CT scan showing this failure of formation of the ring of C1, both anteriorly and posteriorly. And you also can see a hypoplastic, developmentally abnormal C1. And this is another player we were asked to see potentially because his original team thought he was not clear to return. And we all felt the same way, that he wasn't clear. And he ended up retiring from the NFL. And one last case, and I'm looking forward to hearing everyone's thoughts on this one. This is an NFL player who got pulled from a game after experiencing bilateral arm paresthesias with any neck flexion or extension after a tackle. And he was recommended to retire on the basis of his MRI, as he had cervical stenosis at 2 levels, including myelomalacia at 1 level. The patient was asymptomatic and sought opinion from another team doctor in another city. And this was sent to me later after the surgery. What did I think? So here's his post-operative MRI. Here you can see an ACDF has been performed at 4.5. There's still a spot of myelomalacia there. He's got some significant cervical stenosis at 3.4 in this very narrow canal. This is his 4.5 level. And this is his 3.4 level, and this is his 4.5 level. So now what are you going to do? Can he play? And to boot, this is his CT scan on top of it. So he has his asymptomatic pseudoarthrosis, and he's got stenosis at the next level and a spot of myelomalacia. So now the question is, can he play? And that's where we are with this guy. Thanks, everyone.
Thanks, Andy. That was fantastic. Wellington, I think you're still there. Do you want to comment on whether or not you would send that particular patient back to play?
Yeah, that's an interesting case. So a couple of things. One is that he still has cervical stenosis at the untreated level. In fact, if you look at the MRI that Andy put up, he has congenital stenosis at multiple levels. And if you were to measure that on a sagittal T2, it would be less than 8. So again, my criteria is to use that sagittal canal diameter as a no-go criteria despite symptoms. And so that based alone, it would not clear this individual. The fact that he has an asymptomatic pseudoarthrosis, I would not have a problem with clearing an individual with that. But Andy also makes a good point that if he's a defensive back, I certainly would have more trepidation of doing that. So I think the position does matter there.
Yeah, my recommendation was the same as yours, Wellington. This was sent to me for an opinion, and I thought, one, the team doctor who said you need to retire, I thought was right on the money. And he got it fixed anyway, because he thought if he got rid of the level with the myelomalacia, that he would have a chance of returning. But to me, he should have the level with the myelomalacia probably fixed for obvious reasons. And it didn't change the cervical stenosis, but this guy's out there still lurking around. So we'll see what happens.
I'll look for him.
Yeah.
I have a quick question about that patient. Assume he doesn't have a pseudoarthrosis, and assume he's just tight at 3.4 and 4.5. And I just want to get your threshold. I think I know what your answer is going to be, but say you do a laminoplasty on this guy. It's 3, 4, and 5. You get a CT scan at 6 months. The hinge is completely remodeled and healed. Would you, number one, clear him for a collision sport versus a contact sport? What would be your take on this particular guy? And he's got no neck pain, neurologically fine.
We don't have any real good information about football, rugby, MMA fighting, and laminoplasty. There's a couple of reports of some NBA players who have gone back to the NBA after having had a laminoplasty. I think if you had a healed hinge and you were at the right position, I think I would probably let you go back, but there's no data. We really have no perspective really on laminoplasty in collision and contact sports for this, but it's a tough one. And remember, these are young men who also have a long life ahead of them. And as much as they want to go back and be part of it and get back out there, we got to never let them lose sight of the fact that they have another 60 plus years, God willing, of life left. And we want them to have the best life possible. So most of them get it, but sometimes it's a tough pill to digest when we're asking you to step away from the sport that you've loved since you were a small boy.
Yeah, thank you. Wellington, do you feel the same about that?
Yeah, I think those are insightful comments by Dr. Hecht. I would agree with everything that he said. I would add, though, that I've had this conversation with a number of individuals who I would disqualify, but I always throw the laminoplasty card out there to say that it is possible to have that case where you have a healed hinge, you have a stable spine, and although nobody has gone back to a collision sport, I would agree that I would probably let that individual back to play. The other issue, Tom, though, is that I don't know of a team physician that would allow that to happen, take on that risk, even though the treating physician would, or even though a third opinion would, So yeah, but I think there should be hope for individuals with congenital cervical stenosis, and that laminoplasty card is the one I use.
Sure, thank you. I have an interesting question from one of the audience members. Do you routinely get a CT to assess fusion prior to releasing players? And if so, when do you get the CT scan? And I was going to ask a similar question. What is your algorithm for time to return to play after, say, a single level ACDF? Number one, what's the time do you let them to play? Do you automatically assess fusion, and at what point, and how do you assess the fusion?
So I usually get a CT scan. If I have a player who's got a lot of time, I'll use allograft bone. But if I have a player who has a real rapid deadline, I'll use autograft bone. And I like to get a CT scan. With autograft, I won't get a CT till about 4 months or so. It's usually, the soonest I've seen people go back, it's about 6 months. I love seeing a CT that's fused. And I think from the conversation with the athlete, having a CT that shows that it's fused is very helpful. And it's also, especially sort of a peace of mind aspect to it. But there are players who have asymptomatic pseudoarthroses where they have maybe one end of the graft or one end of the cage, or whatever you used, that's healed, but the other end is maybe a pseudo and it's asymptomatic. And maybe I'm a little bit more lax with a quarterback than I am with a defensive back. So the answer of it, what do you do about an asymptomatic pseudo? Can they play? You have to have this heart-to-heart with the athlete. So they know that if they get symptomatic, they're probably going to have to get it fixed. And I've seen a few players at the combine who have had asymptomatic pseudos and have played it and have been drafted high up in the first or second round with that phenomenon and haven't had issues. But at the same time, I've seen others who've developed pseudos, had them fixed and either returned or not returned. So I think when you're dealing with professional athletes, getting information is never going to be the wrong answer. But the soonest I would do it with autograft is about 4 or 5 months, and with allograft, probably 6 months.
Okay. Wellington?
Yeah, I would agree with everything that Andy said. The only thing I would say is that I would wait as long as possible to get the CT. So depending on where that individual was in the season, when they needed to participate in some type of collision sport, I would allow somebody to get back to, running without any contact, even without a CT scan. But if I were to return somebody to the field, I'm going to wait until the very last moment. So yes, the minimum is 4 months, but if it can be 7, 8, 9, 10, I'm going to have a lot more information at that point. So we wait until that moment.
And would you ever clear athletes after a fusion with flexion extension x-rays if there's no motion? Or do you always get a CT scan?
I've never really found flexion extension films to be that helpful other than in the most egregious situations. I find that the CT scan is such an easy thing to get. It's the gold standard. You get so much more information. And we have so many cases we could show of people who have what looks like a fusion on an x-ray, perfect flexion extension, and they have a non-union. So, it's for me, for an NFL player, an NHL player, Division I athlete, I think the information, the gold standard is a CT scan.
Okay. This is an interesting question. I'm going to open it up to either one of you, maybe Wellington first. Can you discuss a case or a circumstance where a player was cleared to play after surgery that had a subsequent trauma with permanent neurological deficit?
So there is no report of that happening within the collision sport, which leads me to believe that a pseudoarthrosis is consistent with return to play. It's because we don't have that scenario where someone with surgery had a fusion, had a collision or a trauma, and then led to a neurologic deficit or injury or what have you. I mean, those individuals can still get neck injuries and still get other types of injuries, but nothing in the literature that sort of indicates that. Now, those numbers aren't very high, so you can't just say that that is enough proof to allow everybody to get back in that scenario. But I think it's good enough for me in counseling the individual, in 2020.
Okay.
Now, most athletes who've had a cord neuropraxia or they've had some significant symptoms, I mean, it scares them. I mean, this is not something they get it, and they don't want to go back until they're really ready to go back. And an athlete who's had more than one cord neuropraxia, who has doesn't have a disc herniation but has a stenotic canal, they're usually going to call it a day.
Okay.
But common sense says it's going to happen at some point. We just haven't seen it yet.
Okay. And this is one for either one of you. How long after a neuropraxia do we consider it safe to return to call it a collision sport?
I like to say when you have full painless range of motion and you're neurologically normal. And obviously, when you have a cord neuropraxia, for that day, it's game over. That's a cord neuropraxia is an evaluation. So all the team doctors, athletic trainers, they all know what that is. And they know what it is, and we get an evaluation, and they don't return until we make sure they don't have a disc herniation. They don't have something that would keep them from playing again. So, but when they're full painless range of motion and neurologically normal, I let them go back. Wellington, what about you?
Yeah, same. I would say it usually takes longer though, because just like you said, it scares them. It scares individuals not into thinking that their season could be over, this and that. Usually it takes a couple of weeks to get all of the opinions on board for an athlete to be comfortable with returning to what they were before. So, but I would agree with you. Yeah, I mean, as soon as you meet the criteria of having the full evaluation from an imaging perspective, full range of motion, painless, normal neuro exam, yeah, I feel that individual is safe to return. So that could be as soon as a week, but we usually see this sort of playing out in weeks and multiple weeks.
Okay, this will be the final question. I want to ask, just present a case, a hypothetical case. Actually, this is a case of an Olympic athlete that presented to me. He was a high jumper, and he had a very large C6-7 paracentral disc herniation. And I'm sure you've seen high jumpers. They come up and they come down essentially on their cervical thoracic junction upon landing, and they roll over. And this guy had gone through, I don't know, probably 1,000 different surgeons across the world, and he ended up in Cleveland. I punted, by the way, to somebody in New York City. But nonetheless, how would you treat this 25-year-old individual he was ranked, I think, second or third in the world, and he needed surgery? There's no way about it. I mean, and so how do you go about choosing in that particular sport, whether or not it's going to be an ACDF, posterior frame rotting, discectomy, and you could get it from the back. You certainly could get it through the back, or disc arthroplasty.
I'm not a big fan of the disc arthroplasty in collision and contact sports. I just think, baseball, that's not really, unless you're going to collide with the wall, you're the catcher, it's very rare to have contact. And in this athlete, every time they land, it's a contact. So, having a one-level ACDF is not the end of the world. I mean, and I think I remember this case. I think you showed me this case once, and I would have done an ACDF on someone like that. But
okay.
But
Wellington? Oh, sorry, Andy. Go ahead.
Yeah, go ahead. Wellington, go ahead.
Yeah, the high jumper is interesting because they need to extend their neck at a very extreme angle in order to clear the bar, right? So I would say that would be a unique scenario, even more unique than collision, because I'm not really worried about the impact of the cervical thoracic junction on a mat because there's sort of give and take there. But I would be concerned about what a fusion would provide in terms of any decreased range of motion in extension. So yeah, I mean, in that individual, if you can do a foraminotomy, I would certainly try to do that with the knowledge that there's a high reoperation rate. And if there does need a reoperation, then I'll probably do a fusion, just like Andy explained.
It was an interesting case, but ultimately he went on to have a disc arthroplasty. I don't know where his career went after that. He may very well still be in the Olympic circle. I'm just not sure. Interesting case though. Well, with that being said, we are past the hour by 5 minutes. I'm going to conclude. First, I want to thank everybody who took time tonight from the participant side to see these great speakers, Dr. Andrew Hecht and Wellington Hsu from Northwestern and Mount Sinai. And if you have any questions after the talk, feel free to reach out to Ron Costello or Mark Reichi from AO Spine, and we can certainly link you with the speakers should you have any burning questions of any kind. And that's going to conclude our session today. Again, thank you all for making time, and thank you, Wellington, and thank you, Andrew.
Thank you.
Thank you.
Guys, good night.